All right, class. Today we're diving into one of the most important public health topics of the last half century, HIV infection and AIDS. Since the first documented cases back in 1981, we've made incredible progress. What started as a terrifying and poorly understood illness has evolved into something we can now manage as a chronic disease with the right care, the right medications, and the right patient education. We've gone from fighting opportunistic infections in the hospital to helping people live full, long lives in outpatient care. That's a huge shift. In the early years, success came from recognizing and treating opportunistic infections. Those are the infections that normally wouldn't make a healthy person sick, but they wreak havoc in someone with a suppressed immune system. Then, in the second decade, we saw the development of HAART, highly active antiretroviral therapy. That changed everything. Now, in more recent years, we've been focused on prevention, medication adherence, and making combination medications easier to take. Still no vaccine, but the science is getting closer. Testing has come a long way, too. The enzyme immunoassay, also called EIA or ELISA, became available in 1984. That meant we could detect the virus before symptoms even started. And now, managing HIV looks more like managing diabetes or high blood pressure if we catch it early and stay on top of it. Let's talk epidemiology. The CDC has revised its definitions of HIV infection and AIDS multiple times. In 1985, 1987, 1993, 2008, and again in 2014. That's how fast diagnostic science evolves. Today, a confirmed case of HIV can be based on lab or clinical evidence, but labs are preferred. We now classify HIV into stages: 0, 1, 2, 3, or unknown. Stage 0 is early infection. Stages 1 through 3 are based on CD4 counts. Stage 3 is what we used to call full-blown AIDS, and if a person has a stage 3 opportunistic illness, they're automatically considered stage 3, even if their CD4 count is decent. Now, here's where things get real. According to the CDC, over 1 million people aged 13 and up are living with HIV in the US, and over 500,000 are living with AIDS. The diagnosis rates have slowed a bit thanks to better treatment and prevention, but the numbers are still significant, especially among men, particularly young men who have sex with men. We're also seeing disparities by race. Black Americans have the highest rates, followed by Hispanic Latino individuals and people of mixed race. Age-wise, the highest infection rates are in people 25 to 29, followed by 20 to 24. And regionally, the South carries the highest burden of new infections. Globally, the World Health Organization reports that HIV has claimed over 32 million lives. In 2018 alone, 770,000 people died of HIV-related causes. That same year, almost 38 million people worldwide were living with HIV, most of them in sub-Saharan Africa, which accounts for nearly 2/3 of all new infections. But here's the good news. Between 2000 and 2018, new infections dropped by 37%, and deaths dropped by 45%. That's 13.6 million lives saved, because people had access to effective treatment. Let's shift to transmission. HIV-1 is found in body fluids like blood, semen, vaginal secretions, amniotic fluid, and breast milk. The more virus in the fluid, the higher the risk of infection. Breaks in the skin or mucous membranes, like sores or inflammation, make transmission more likely. The virus is not spread through casual contact, not by hugging, not by sharing a toilet, not by shaking hands. Mother-to-child transmission can happen during pregnancy, delivery, or breastfeeding, but most often it's during labor and delivery. Now let's address the elephant in the room: blood transfusions. Back in the early 1980s, this was a real concern. Today, the risk is virtually eliminated. Donated blood is rigorously tested for HIV-1 and HIV-2 antibodies, plus P24 antigen. Add in improved virus inactivation and heat treatment of clotting factors, and it's one of the safest things we do in medicine. Here's a quick rundown of high-risk factors from Chart 32-2. Sharing injection drug use equipment, unprotected sex with infected partners, being born to an HIV-positive mother or breastfeeding from one, receiving HIV-infected blood or organ transplants, especially before testing, improved in the mid-1980s. Now let's talk about a group we don't often think of. First, older adults. Over 230,000 people aged 60 and up are living with HIV or AIDS in the US. Many were diagnosed years ago and are living longer thanks to treatment. But here's the issue. Older adults are less likely to be tested. 35% of new diagnoses in this age group are already at late-stage disease. Why? Because of stigma, assumptions by providers, and the mistaken belief that older adults aren't sexually active. Providers may also feel awkward talking about sex or drug use with seniors. That needs to change. Older patients with HIV often have other health issues, things like cardiovascular disease, diabetes, cancer, depression, osteoporosis, and all of that means polypharmacy. Drug interactions are a real concern. And let's not forget the emotional side. Loneliness is huge. One study found that 58% of older adults with HIV reported some degree of loneliness, and those who felt lonely were more likely to smoke, misuse substances, and struggle with depression. So what can we do as nurses? We educate. We teach patients how HIV is transmitted. We offer culturally competent care to LGBTQ+ patients who face stigma and isolation. We talk about PrEP, pre-exposure prophylaxis, for those at high risk. That's one daily pill with 2 meds, taken before exposure to reduce the risk of infection. But patients still need condoms. PrEP doesn't protect against other STIs. Speaking of condoms, patients need to know how to use them correctly. We're talking about putting it on before any kind of sex, squeezing the tip to get the air out, unrolling it fully, holding it during withdrawal, and never reusing it. Oil-based lubricants like baby oil or petroleum jelly can break down latex, so stick with water-based lubricants like KY jelly. Female condoms are another option, inserted by the woman, and they block genital secretions. And researchers are still working on woman-controlled options like microbicides, gels and suppositories designed to kill viruses. Nothing fully proven yet, but trials continue. Now let's talk about people who use drugs. We know total abstinence isn't always realistic right away. That's where the harm reduction model comes in. Needle exchange programs, safe disposal, referrals to care, all of that saves lives. These programs don't increase drug use. They decrease HIV transmission. Nurses should refer patients to them without judgment. In terms of reproductive health, women need counseling too, especially if they're thinking about pregnancy. For discordant couples, artificial insemination and ART can reduce risk. And in resource-rich countries, HIV-positive moms should not breastfeed. Let's wrap with one more group. Us. Healthcare workers. The risk of acquiring HIV from a needle stick is about 0.3%, very low. But if it happens, it's an emergency. Every hour counts. Post-exposure prophylaxis, PIP, needs to start within 72 hours. The standard regimen is 3 drugs. We follow up with HIV testing at multiple intervals, monitor labs, and provide counseling throughout. And of course, none of that should be needed if we follow standard precautions. Proper hand hygiene, gloves, gowns, goggles, sharp safety, and appropriate PPE. Every patient, every time. No exceptions. There's still no vaccine, but researchers are working hard on that. When it comes, it'll be a game changer. All right, y'all, that's it for part 1. You now have the background, the stats, the transmission facts, and the basics of prevention and safety. In part 2, we'll get into the pathophysiology of HIV, what the virus actually does inside the body, and how we monitor and treat it.